Welcome, everybody, to our University of Miami Cerebrovascular and Skull-Based Symposium. This week's series will be held today from 5 to 7 p.m. Eastern Time, held every Thursday here live from the University of Miami. This is now our 12th session, started on May 21st, and has been very successful. We hope to keep it going through the end of 2020. My name is Carolina Benjamin, and I'm speaking today on behalf of my partner, Dr. Ivan-Morcos, who is stuck in the OR currently. Dr. Morcos has done a fantastic job organizing and spearheading this effort and really just keeping us all together academically during this pandemic. So he is a professor and co-chairman of our Department of Neurosurgery, as well as otolaryngology, director of our cerebrovascular surgery, as well as skull-based surgery at the University of Miami. Again, my name is Carolina Benjamin. I'm one of the co-directors. I'm an assistant professor here at the University of Miami, as well as the director of the Keynes Cadaveric Lab, and specialize in brain tumor as well as skull-based surgery. And Dr. Michael Ivan is another one of our co-directors. He is assistant professor here at the University of Miami, director of research of the Brain Tumor Initiative, and specializing in brain tumor, skull-based, as well as epilepsy surgery. We are also joined by our cerebrovascular, open and endovascular colleagues, Dr. Bobby Stark and Dr. Eric Peterson. And Dr. Stark is also the Director of Endovascular Research here at the University of Miami. Here we are in Miami. It's very hot and humid now, and this is our medical campus at the University of Miami, as well as Jackson Hospital System, where hopefully things with COVID are starting to stabilize a little bit. And here we are. This is the link for you to register and attend all of these sessions up top in the arrow. You can also access all of these on YouTube. We started these May 21st, have had some really great talks and great discussions all throughout the summertime and continuing on, hopefully through the end of the year. Some housekeeping rules. So audience members, if you could use the Q&A box to send your questions, both myself, the other co-directors, and the panelists are going to select some questions for discussion with the group at the end. We are not currently offering CMEs, but you will get an email confirmation of attendance in a few days. If you like these sessions, share the links as well as the program with your colleagues, email or your own social media account, or however you'd like to distribute. And our speakers today will be talking for about 25 minutes each, and we may have to interrupt the speakers with a 2-minute warning just to be able to keep us on schedule. This is something new that Dr. Morcos introduced the last time, but we'd like to hear from you, what sessions you'd like to hear about, either topics in CV and skull-based or what speakers you want to hear from. So if you have suggestions, please let us know. You can send them in the Q&A box here today. You can email Dr. Morcos or reach him through Twitter or any other of the panelists, and as well as the co-directors would be happy to send this along to Dr. Morcos. As a teaser for next week, we have our session will be about carotid endarterectomy and carotid occlusive disease. We'll have Dr. Wilson and Dr. Harbaugh, as well as a great group of panelists here. And in parallel with this Thursday evening symposium, Dr. Ivan has also done a really great job organizing another symposium that's on Wednesdays from 5 to 6:30 p.m. every week. And here's a little teaser for next week. We'll have Dr. Carter speak about personalized brain tumor diagnostics and therapy, where we are in 2020. Dr. Morcos takes a minute to thank our support staff every week, and I will do that as well. Ingrid, Christina, Robert Suazo, and Iggy. Really, these symposiums would not be possible without all your hard work, and we are all very grateful for all the efforts behind the scene. Here is another just another slide showing you all the different ways to get in touch with us, either through the website or directly with Dr. Morcos or the University of Miami, Twitter, Instagram, or the website. Feel free to reach out to us with any questions. Now, to the exciting part of the evening, our panelists and speakers. So today we're joined by Dr. Fred Gentili, Professor of Neurosurgery at the University of Toronto. Dr. Anil Nanda, Professor and Chairman of Neurosurgery at Rutgers, Robert Wood Johnson, and New Jersey Medical Schools. Dr. Jamie VanGompel, Associate Professor of Neurosurgery at the Mayo Clinic, and our very own Dr. Ivan, Assistant Professor of Neurosurgery here at the University of Miami. And for our speakers, Dr. Angeli is a Professor of Clinical Otolaryngology and Neurosurgery at the University of Miami, Director of the Neurotology Fellowship, as well as the Director of Miami Ear Institute. I'm sure Dr. Morcos would have some personalized joke about each of you, but I will keep it to the basics. He was born and raised in Caracas in Venezuela and attended the Universidad Central de Venezuela here on the left. Did his residency in ENT at the University of Iowa and a neurotology fellowship at the House Clinic in LA. You can see the list here of a multitude of both clinical as well as research interests, a leader in surgical education, and Dr. Morcos' partner in crime in the OR, so they have a very special relationship. And today, Dr. Angeli is going to be speaking to us about the temporal bone and what the neurotologist can teach the neurosurgeon about the temporal bone and the specific approaches. And we also have our second speaker, Dr. Miguel Arraez, joining us today from Malaga. He is the professor and chairman of the Department of Neurosurgery at Carlos Haya University and the University of Malaga, Spain. Chairman, WFNS Foundation, as well as the vice president of the WANS. So thank you for coming. I think it's 11 p.m. there now, so we really appreciate you joining us so late. Dr. Arraez was born in Almeria, Spain, and did his residency in Virgen de las Nieves University Hospital in Granada. He's a member of editorial boards of several journals and focuses on skull-based pituitary brainstem as well as neuro-oncology. We are very excited to have him here today, who will talk to us about surgery of petrous apex pathologies, philosophies, strategies, and techniques. So without further ado, I'll have Dr. Angeli, if you could please share your screen, unmute your microphone, and then you can start the presentation. Dr. Angeli, I think you are on mute.
No, he's unmuted.
All right. Can you hear me now? Can you hear me now?
Loud and clear.
Thank you. Well, can you see my screen now?
Yes, we can.
Yeah, looks
Okay,
good.
thank you. Well, Carolina, thank you very much for that nice introduction. I guess I was spared Dr. Morcos' joke, so I'm happy. I'm very excited to be sharing this initiative with you all today. Jacques was the creator of the title, you know, what the otologist or the neurotologist can show or can teach the neurosurgeons. I'm not sure I can teach you guys much. I'm just going to share some of my perspectives on some of the approaches. I've seen this over the last years, how the neurosurgery residents are keen on coming to the temporal bone lab and even drilling alongside my ENT residents. So I think it's going to be fun to discuss some of these perspectives together. So the obligatory disclosure slide, and I want to acknowledge my colleagues and some of the fellows too that had something to do with the presentation today, either sharing slides or making comments on the presentation or just working alongside me every day. So we're going to talk about temporal bone approaches and how do we choose the best approach. And you know, as you all know, we have to do a very detailed evaluation of our patients. You know, there are many demographic, clinical, and disease-specific factors that you know, base our decision which approach to use, or even whether we need to do surgery or something else. We have to be very clear of the goal of the procedure. So do we want to do a biopsy only, or are we planning to do a subtotal resection, or are we trying to do a total resection? So all those questions are important. And of course, we have to know the patient's pre-existing neurological deficit and consider the ones that we're going to cause with our approach. All of that comes together, and I know you're very experienced when you see these patients, but it's important that we complete our evaluations before making a decision. And one more important point is the institutional and surgical team's experience. Sometimes we are very comfortable with one approach, but not another approach that we see written or published in a paper. So it's important that we're honest with our patients when we offer these very complicated surgical approaches. Preoperative evaluation includes, of course, a cranial nerve examination and the evaluation of the deficit. We do a hearing test to confirm the presence of hearing, or whether it's serviceable. We kind of like to use serviceable hearing or call it serviceable hearing when we have a pure tone threshold of about 70 decibels, of about 30 decibels with a word discrimination of 70%. Because less than that is very difficult to habilitate with a hearing aid. I just want to remind you that we offer here at the Department of Otolaryngology all sorts of hearing and auditory prosthesis. So we can that's the second part of our relationship with the patient. Not only we take care of their tumor, but we also try to reestablish their neurological function when we can. Imaging studies is very important. MRI and CT scan are complementary, but sometimes we have to do more complicated tests like a balloon test occlusions for tumors that are around the carotid. So today we're going to concentrate on the temporal bone approaches, and we're going to discuss the retro-labyrinthine approach, the trans-labyrinthine approach, as well as the transcochlear transodic. And at the end of the talk, I'd like to show you a short video of a retrosigmoid approach from the neuro-otologist perspective. Let's see if we can show that at the very end. So what the retro-labyrinthine approach is a relatively easy approach that affords a small but useful exposure of the cerebellopontine angle. Has relatively very few potential complications. Doesn't have the you can't spare the hearing and vestibular function when doing this approach. But of course, the disadvantage is that the exposure to the posterior fossa is very, very limited. This approach was created mainly for the management of Meniere's disease for the vestibular nerve section. So we can combine it with other approaches when necessary. But this is a beautiful cadaveric slide, and I'm going to present many of these from a study by Dr. Morcos, Coscarella, and Tumala. I remember these heads lying around in the temporal bone lab everywhere, and I kick in the bucket on the floor. But they really a very nice presentation. This is a right ear, or you're looking from the surgeon's perspective. We have the facial nerve all dissected here. Most of the bone of the temporal of the mastoid has been taken away. This is the jugular bulb, the sigmoid sinus, and this is, of course, the retractor is on the cerebellum, and we can see the posterior semicircular canal and the superior semicircular canal under the superior petrosal sinus here that has been folded. So we can see a portion of the 8th cranial nerve, perhaps no more than 2/3 of the medial portion of the cranial nerves. This is an example of a tumor that was managed with a retro-labyrinthine approach when we were just approaching the posterior fossa portion of this tumor. And you see the dissection under high magnification and suction irrigation, identifying the superior semicircular canal and posterior semicircular canal. It's important to expose the entire pre-sigmoid dura. And to do that, sometimes you have to decompress the sigmoid sinus, and including the retro-sigmoid sinus dura, so you can compress on the sinus and approach the area. Just more visualization, the superior posterior canal preserved intact. You see in the posterior fossa in this area, and of course the tumor here more. The middle fossa plate has been taken down and retracted, so you can see the structures in that area as well. And this is a postoperative view of that case. As I said, this retrolabyrinthine approach was designed mainly for vestibular neurectomy in Meniere's disease. And we used to do a lot of these cases, perhaps kind of nice, but you have to see that you have to make sure that your patient's anatomy affords enough visualization through the retrolab. And that's why it's important to check your CT scan. You know, if you encounter a case like this one with a very procident sigmoid sinus, very solid mastoid and high procident and dehiscent jugular bulb, you're going to have very limited exposure, and perhaps that's not the best case for a retrolabyrinthine only approach. Now, back in 1999, Sekhar and his group, they started combining these petrosal approaches with the middle cranial fossa approach, or the temporal craniotomy approach. And they, at least were the first ones that I know, published a series using what they call the partial labyrinthectomy, where they would resect the posterior and superior semicircular canals, as well as a petrous apicectomy, to gain a little more exposure to the posterior fossa, and yet preserve hearing. And I can tell you, there's quite an experience of obliterating semicircular canals and being able to preserve hearing and balance if you do it the right way. We recently published a paper showing that you can, you know, in more than 80% of the cases, you can do that. So this approach will give us a little more exposure when needed. In fact, I'm quoting this paper by Horgan, where they actually compare the exposure through the partial labyrinthine approach, giving it compared to the transcochlear, which is the greatest exposure that we can get from the temporal bone, and the surgical freedom. Of course, the retrolabyrinthine approach was the one that had least amount of exposure. See, these are the prominence of the semicircular canals that are taken down, and this is a case of a PETROCLIVAL meningioma that we approach through the supra and infratemporal approach. Doing in this view, you see how we blue line or outline the semicircular canals. Subsequently, we plug them and eliminate and drill them, as well as a drilling of the petrous apicectomy area, dissecting the superior portion of the internal auditory canal, and that gives us a corridor to expose the anterior petrous apex and anterior petroclival area. And this is the end result with the fat graft filling up the area. So this is a Sekhar paper in I remember reading this right out of my fellowship. And some of the important things about this paper is that they quoted a 33% chance of cerebrospinal fluid leak. So in the later cases, they started obliterating the eustachian tube, and it kind of defeats the purpose. If you want to do a partial labyrinthectomy to preserve the hearing, yet you have to obliterate the eustachian tube and cause a hearing loss, you know, from causing middle ear dysfunction, then it doesn't quite defeat the purpose. So we recommend instead than obliterating the eustachian tube, doing a closure of the aditos ad antrum, as I'm going to show you in this video. Now, this is a right retrolabyrinthine approach. This is sigmoid sinus, and we see the small area of the dura that we couldn't approximate with the stitches. So we bone graft or bone chip or anything is placed in the aditos ad antrum to block the mastoid portion from the middle ear space. Then we cover that with temporalis fascia, and the fat graft fills up the entire area. And we can preserve that the function of the eustachian tube and the middle ear. Now, if we need even further exposure, and you know, the more anterior exposure that we require, the more morbidity we create. And the translabyrinthine approach is kind of the workhorse of the neurotologists, you know, where we are, it's a direct route to the posterior fossa, many times directly to the tumor. And most of the work is done extradurally with minimal or no retraction of the cerebellum or brain. The other advantage of the translabyrinthine approach is that it gives us an exposure to the entire facial nerve, not only for to help identify the plane of, between the facial nerve and the tumor, but also in case that we needed to graft the nerve, we can either reroute and extend the nerve to make end-to-end anastomosis, or have more flexibility at the time of repairing the nerve. Of course, the hearing is sacrificed and the balance function as well. And there is a relative disadvantage of on tumors that extend caudally when you have a very high jugular bulb or a very anterior sigmoid sinus. Again, the beautiful cadaveric presentations. Here's the facial nerve in its the mastoid portion, facial recess approach, the jugular bulb, the entire dural plate of the posterior fossa has been open. The internal auditory canal has been opened 270 degrees, so you can see the entire content of the ISC or the internal auditory canal, but you can follow the facial nerve along into the labyrinthine segment, then to the genicular ganglion, and even into the middle ear if you needed to, and back into the area of the mastoid. If you needed to graft a nerve, and if you have a large gap, you can decompress the mastoid segment and just bring it down towards the CPA where you have your other end of the nerve. And also you can reach a portion of the nerve away from an acoustic neuroma and find that plane. It's just very practical for that, as we see here. Drilling around the porus, eliminating the entire ring of the porus acousticus, also gives you enough exposure to the posterior fossa. That's the facial nerve. And yeah, we can tackle pretty much any tumor in the cerebellopontine angle that doesn't extend too far anterior, like we see here with the direct approach. And this is after the tumor has been removed and the fat graft placed and the craniotomy reconstructed. Now, the transcochlear approach was at least popularized by House, and the first paper on this came out in 1977. And they were using the transcochlear approach without any temporal craniotomy for very large tumors that extended ventral to the pontomedullary region. And these, of course, were usually large meningiomas, the ones they have in their series, but also chondrosarcomas and acoustic neuromas and other types of tumors. Oh, there's a lot of drilling involved in the transcochlear approach. But fortunately, most of the drilling and the work is done extradurally and with minimal retraction. Also affords good, of course, the exposure to the facial nerve. However, the classical transcochlear approach requires a transposition of the facial nerve, which typically results in some facial nerve dysfunction. Here we see, after identifying the genicular ganglion and sectioning the greater superficial petrosal nerve, the entire decompressed facial nerve is brought back, and then the cochlea is drilled, station tube, and then the internal carotid artery is identified. And you can follow that petrous carotid artery into the petrous apex and cavernous sinus that way. Carotid artery, the cochlea, that can be taken down for more exposure. And some of the views, through the view, you can get all the way to the clivus and basilar artery. This is a case of a recurrent giant facial neuroma that went all the way to the clivus. In this case, patient had a total facial nerve paralysis, and we wanted to, that occurred recently. We went and found the medial portion of the nerve, but we had to resect the tumor, so we needed access to the mastoid segment of the facial nerve and placed our graft from the cerebellopontine angle to the mastoid in a relatively easy manner using this approach, and resected the entire tumor. You see the cochlea is no longer visible here. Sometimes we have to do this approach for very invasive epidermoid tumors. One important thing about the transcochlear approach and many of these approaches is the potential for cerebrospinal fluid leak, especially when you resect a large portion of the dura and it's difficult to reconstruct. The original description did not include closure of the external auditory canal, but we recommend that in our cases when we do extensive dissections in the posterior fossa. And especially if you're doing a translabyrinthine or a transcochlear approach, as we're going to show in this video, this is the same lady with a revision surgery. She already had, this is a left ear. She had already mastoidectomy. We're elevating the skin of the ear canal, identifying the posterior wall, bony wall of the ear canal, sectioning the soft tissue. And the advantage of doing the closure of the extension tube and plugging, the closure of the external auditory canal and plugging the tube is that, of course, you minimize the chance of a cerebrospinal fluid leak. And if it leaks into the wound, it's typically contained within the wound and it's not leaking out. So this makes your life a lot easier. Replacing the stitches after we separate the skin of the underlying cartilage so we can invert. We're placing now a Kelly clamp through the ear canal, and then we're going to pull our stitches out of the ear. And close the canal. Nowadays, we seldom do the transcochlear approach by itself. Typically, we do most of these transtemporal approaches in combination with a temporal craniotomy, which affords a lot more exposure and perhaps limits the amount of drilling that we have to do into the labyrinth. But I believe the next presenter will discuss this in more detail. This is a typical preparation for a transcochlear approach, and your anterior incision will go as far as anterior as you need to. Typically, in these cases, we use neuronavigation, and here is the greatest Dr. Morcos at the helm of the navigation system. Now, just to finish up, even though I've been discussing the pre-sigmoid approaches, but I want to start with this short video with its own audio that we created for illustrate the versatility of the post-sigmoid approaches or retro-sigmoid approaches.
Our case involves a 54-year-old
So I'm
gentleman
going to shut up and let the video run with
left-sided hearing loss and
voice.
imbalance. The audiogram showed an asymmetric left-sided moderate to severe
on.
sensorineural hearing loss with poor speech discrimination, class C. The MRI, as you can see here, demonstrated left-sided intracanalicular vestibular schwannoma. Management options including observation, radiation, and microsurgical resection were discussed with the patient, who ultimately opted for surgery. A retrosigmoid approach was chosen as a means to potentially preserve any residual hearing. This is a demonstration of the lateral park bench position we use for our retrosigmoid approaches. So you can see the contralateral arm hangs with padding to ensure no contact points, as well as a pulse ox to make sure he has good vascularity. There is also mild lateral flexion as well as forward flexion of the head. From a different viewpoint, we can see there is also slight contralateral rotation of the head with downward retraction of the ipsilateral shoulder. This facilitates optimal working space. Intraoperative ABR monitoring is conducted. However, as you can see, there were very poor waveforms in the ipsilateral ear at the onset of the case. The facial nerve monitor is also set up with stimulator settings at 0.05 milliamps. This is an image of our typical skin markings demonstrating our incision and planned craniotomy site as they relate to the transverse sigmoid sinus junction. Once exposed, the dura is incised, arachnoid adhesions are dissected, and CSF is drained from the foramen magna. This results in relaxation of the cerebellum, which falls away from the petrous bone, allowing exposure of the porous area without any or minimal retraction, as you can see here. With no tumor in the cerebellopontine angle, we have a clear view of the porous, cranial nerve 7 and 8 complex, a loop of the ICA, and the lower cranial nerves inferiorly. We begin our drilling with large diamond burr, size 4 usually. So you can see here the dura has been reflected medially to protect the nerves. The suction irrigator is rested against the telfa and the cerebellum, keeping these in place. A combination of irrigation and natural CSF pulsations is used to rid the field of any bone dust. Following sequential saucerization of the petrous bone with smaller diamond burrs, we begin to identify the ISC and trace it laterally with care not to inadvertently enter the vestibule. Inferior and superior troughs are developed for a 270-degree blue lining of the ISC. Once the overlying bone is thinned to an eggshell, it could be carefully removed with a round knife, as described in the Jacular Atlas of Skull-Based Surgical Anatomy. This then facilitates incising the IAC dura to expose its contents. Having incised the dura, we now have direct visualization of the tumor. With gentle retraction, you can also appreciate the facial nerve and the tumor nerve interface. Here we are gently developing this plane with small round knife and gentle tumor retraction using a size 5 PMT suction. At this point, the distal attachments of the tumor to the remaining healthy superior vestibular nerve are sharply transected. This is done with care not to injure the underlying facial nerve or the cochlear nerve. With the aid of a Roton 6 and further suction retraction, the tumor is systematically rolled from a lateral to medial direction in a broad front to avoid excessive pull on the facial nerve. Once arriving at the porus, one can appreciate the remaining attachments of the tumor to the porus dura and the facial nerve. The preserved cochlear nerve could be seen inferiorly. Here the tumor is rolled and remaining attachments are released using the facial nerve monitor, again set at 0.05 milliamps. At the conclusion of the case, we use a 70-degree endoscope and visualize the fundus of the IC to ensure that no tumor is being left behind. This also allows us to see if there are any air cells that will require packing.
Excellent. So, if you needed to, and if you don't care about hearing, you can also extend your dissection of the ISC into the labyrinth, into the vestibule first, and even follow the facial nerve deep into the labyrinthine segment. So, in cases where hearing is not important and for whatever reason you need to have the access to the distal facial nerve, you can continue that dissection through the labyrinth. So that concludes my presentation, and thank you, Carolina, and the panelists, and I look forward to any questions.
Thank you. That was excellent. All right, if you could stop sharing your screen, and then Dr. Arraez, if you could share your screen now, please.
Good afternoon. Can you see my slide?
Yes, we can.
Okay, Carolina, can I start the presentation?
Please.
Okay, so first of all, I'd like to thank Professor Morcos and Carolina Benjamin and all the team for the kind invitation to participate in this wonderful skull-based symposium. I'd like to congratulate also my partner in this session, Dr. Simon Agnelli, and I have to mention that yes, you have many things to teach neurosurgeons, and I very much enjoy your presentation on temporal approaches. My talk will deal with surgery of petrous apex lesions regarding philosophy, strategies, and techniques. I think that this is a kind of surgery very much domain by anatomy. We can see here this classical slide from the early 80s. You can see at the left side, this is the trigeminal ganglion, the third division, second division, first division, superior petrosal sinus, the petrous apex itself, and the carotid artery with the GSPN, greater superficial petrosal nerve. And just here, we can see the relationship with the petrous apex, with the glycerin ganglion, also with other nerves inside the cavernous sinus. Bottom left, we can imagine how going through the petrous apex, we can get the CP angle and PETROCLIVAL region. And bottom right, this is a more comprehensive view regarding the intra and extradural structures. This is petrous carotid artery. This is the cisternal segment of the fifth nerve. This is glycerin ganglion. This is the inferior petrosal sinus. You can see here the content of the internal auditory canal, fourth nerve, sixth nerve. And in summary, we can see how petrous apex region in broad sense is a very complex area. So we will try to deal with the two main philosophies of surgery. Thus far, one of them is microsurgery, the other one is endoscopic surgery. If we talk about microsurgery, I think that there are a very constant several steps we have to follow irrespective of the situation of the lesion. Just at the petrous apex, the bony petrous apex, or just intradural. And we have to, first of all, do a craniotomy with zygomatic osteotomy or orbitozygomatic osteotomy. We will mention something regarding our philosophy. We think that COC is very restricted, must be very restricted to several complex pathologies involving as well the orbit. We have to, from lateral to medial, identify the middle meningeal artery, medial to this structure, the third division of the trigeminal nerve. We have to do the peeling of the trigeminal nerve complex, that is to say, sparing the temporal dura from the nerve and ganglion. Medially, we will see the greater superficial petrosal nerve and internal carotid artery at its petrous segment. We have to mention, as we can see here, that very frequently there is no bone, and just in case some cartilaginous layer that may provoke some damage of the internal carotid artery if we are not very aware of that peculiarity of the anatomy. If we go to the first category, lesion involving the petrous bone, I think one of the typical examples is cholesterol granuloma, as you can see here. Obviously, this is carotid artery. Medial to that, the petrous bone, in that case, occupied by the cholesterol granuloma. Of course, we very frequently see cholesterol granuloma in our practice, and we only advise surgery for those symptomatic lesions. And this is the right side. You can see the peeling of the fifth nerve. This is the temporal dura. This is the third division, second division of the trigeminal nerve. This is the lesion exposed And medial to that, this is the petrous carotid artery and the GSPN fortunately preserved. This is another example. This is a cholesterol granuloma, always the same disposition of the anatomy. This is the middle meningeal artery, medially the third division of trigeminal nerve, medial petrous carotid artery, medial the lesion itself. We operate this case more than 25 years ago, and at that time, the peeling of the trigeminal complex wasn't popular, and at that time, trying to remove the lesion completely. In some cases, we used to cut the third division of the trigeminal nerve, and this is what we did in that case, and this is actually the only way just to see the second, we are at the left side, this is the only way to see the second loop of the carotid artery. You can see the second loop right before getting inside the cavernous sinus, and this is the lesion apparently completely removed. We lost the patient for the follow-up. The patient came from another province, and many years after, the patient came back with a huge recurrency, and this is the view of this recurrent cholesterol granuloma. This is lower; these are lower cranial nerves, and the image at the CPA. So, for those who think that cholesterol granuloma is an indolent pathology, you can see here this very striking example of how much care we have to do when removing the lesion and trying to be sure that we completely solve the problem. Another typical example at the petrous apex is chondrosarcoma. You can see the lesion relationship with the internal carotid artery, the area where the lesion has been transecting the dura at the posterior pyramid, the petroclival dura, and how the lesion is getting inside the posterior fossa. And after transpetrous resection, you have to do all the steps we mentioned before, and you have to follow the lesion, and the lesion is leading you to the posterior fossa, and this is right side after transpetrous resection. We can go to the second category. Second category is composed by lesion growing extradurally and interdurally. I think this is synonymous of lesion just involving the trigeminal ganglion, as you can see here. And we can see one of the examples. This is a psychiatrist with episode of diplopia and headache. You can see the lesion at the right side. This is a lesion interdurally placed and at the same time extradurally placed. You can see the lesion. And I think that going to the philosophy for removal of those interdural and extradural lesions, we can see many references in the medical literature: epidural interdural approach, frontotemporal approach, infratemporal fossa interdural approach, many different description of one single concept. You have to try to remove the lesion going extradurally, that is to say lifting the temporal dura, exposing, as we mentioned before, V3, Gesheran ganglion, and you will see the lesion. Important by means of the drawing to keep in mind the anatomy. This is porus trigeminalis, that is to say where the trigeminal nerve is getting inside Meckel's cave. This is the trigeminal cister, that is to say CSF getting inside Meckel's cave. And in summary, we have to follow this direction, trying to extradurally remove this apparently simple case. But it's important to keep in mind what may happen. This is a slide courtesy of Professor Takeshi Kawase, showing how variable and different can be the venous anatomy at the extradural region. We can see many variations of the sphenobasal veins and infratemporal veins that frequently are very prominent and may provoke a very difficult and bleeding, troublesome approach, extradural approach to this area. And this is what happened with our psychiatrist. And if you see this intraoperative view, we just had a lot of bleeding and we decided just to open the dura and follow the operation intradurally. And just after lifting up temporal lobe, you can see the bulging lesion and you can figure out how prominent those infratemporal and sphenofacial veins were. So that way you can very easily, in this small case, open the dura mater, removing the lesion, and in that case, fully preserving the anatomy of the fifth nerve. This is another case very similar. This is a lesion interdural and extradural. You have to try to do this very well described extradural approach, but sometimes you can get into trouble, and do not hesitate to open the dura and just making some very easy intradural approach. This is the exposure of the lesion, and at the right side you can see how fortunately we managed to preserve the second and third division of the trigeminal nerve. If we go to the third category, we are talking about lesions that are at the same time going extradurally and intradurally. There is another typical example, again, trigeminal schwannoma. I like very much this paper published in 1999 by Dr. Yoshida and Dr. Kawase. This is a picture taken in Indonesia, in Bali Island, many years ago, maybe 10 years ago or something like that. And in this paper, they describe how trigeminal neurinoma is the only lesion that at the same time can grow intradural, as you can see here, when following backward the segment, the intracisternal segment of the trigeminal nerve, extradurally, intracranially, and also extracranially, when sometimes the lesion is following the third division toward infratemporal fossa. This is one of the lesions, one of the trigeminal nerve neuroma. In that case, following the first division of the trigeminal nerve. And this is, to our knowledge, the only clear indication for the COC, cranio-orbitozygomatic approach, trying to expose the intraorbital content, because otherwise, if you want to do some sort of osteotomy, you can do a limited zygomatic osteotomy, allowing you to lift downward temporal muscle, trying to diminish the retraction of the temporal lobe. And this is the way, in that case, we managed to almost complete remove the lesion. This is the lesion, some small remaining tumor here. We left the tumor here because of progressive intraoperative damage of the oculomotor nerves, already damaged, but partially. So we left this part of the tumor, but see just this huge recurrence several months ago, involving again the orbit and also growing toward posterior fossa, following the trajectory of the fifth nerve, and this is the lesion. And in that case, we went back through the same surgical approach. In that case, we just managed to endoscopic remove the intraorbital content of the lesion, and this is the postoperative MRI showing a pretty good result after removal by means of that combined microsurgical endoscopic assisted removal. We can move to the last part of the microsurgical philosophy for the management of the Petrus apex region lesions. We have to mention something about the extended middle fossa approach. You can see this lesion that is first growing at the Petrus apex. See the distortion of the carotid artery. See how the lesion is at the same time growing inside the posterior fossa, and see the PETROCLIVAL area, the fifth nerve. And extended middle fossa approach is taking advantage of the philosophy of the removal of the Petrus apex, in that case remove. You can imagine at the deepest part the inferior petrosal sinus, carotid artery already exposed, third division of trigeminal nerve, you have to cut in this parallel fashion the lower aspect of the temporal dura. You have to coagulate or clip according to the caliber the superior petrosal sinus, and also making some sort of cutting of the petroclival dura. You can get access to the posterior fossa. This is taken from a publication from as far as 1994, Dr. Sen and Dr. Sekar talking about the advantages of this approach. And this is the opening you can make at the petroclival region, trying to get inside the dura. To my mind, indication for that extended middle approach are basically, as I have showing here, lesions that at the same time are growing at the petrous apex and petroclival region. There are indications for meningioma. I have to confess that almost never I have done this approach for petroclival meningioma. And there is also another indication for lesion growing at the anterolateral pontine region, sometimes pontine cavernous angioma, as I mentioned, a third indication to my mind. And if we go to the surgical technique, in that case, we are at the right side. First of all, in that case, some difficulty to identify and to distinguish between the middle meningeal artery and the third division of the trigeminal nerve. We managed to identify, and after that coagulate middle meningeal artery. We can see at the right side of the dissector. Next step, this is the middle meningeal artery dissect. This is the third division, the peeling of the trigeminal nerve. This is GSPN. We will move forward. And now we are just reflecting the dura and exposing the petrous apex. This is GSPN, fortunately preserved. And until which extent we should reflect and dissect and make the peeling of the trigeminal nerve. You have to do that until the moment your dissector is able just to move around the petrous wedge, as you can see here. And this is the moment you can stop the peeling of the trigeminal nerve. It doesn't make any sense going dissecting further. We start to drill. This is normal petrous apex. We will see how the drill is just going deeper inside abruptly, because we just found in that particular moment that the resistance consistency of the bone is less due to the tumor. As I mentioned, we have to drill the petrous apex, and this is the way you have to drill until exposing petroclival dura. We have to keep in mind that posteriorly you will find the internal auditory canal. Posteriorly and laterally we can damage, according to the anatomical position, we can damage the cochlea. We have to take care of that. And the way of drilling and removing tumor. Okay. This is a tumor, atypical chondrosarcoma. And this is the view after removing, in as much as possible, taking care, because of the deepest part we can find, according to the anatomy, jugular vein and of course inferior petrosal sinus. This is petrous carotid artery, and also always the lesion occupying the petrous apex medially to the internal carotid artery at the petrous segment. If this is the third division of the trigeminal nerve, if we want to see the origin of the tumor as at the petroclival junction, we have to either cut in the third division, of course not advisable, or as we like to do in some cases, using the endoscope, and the endoscope 30 degrees will allow to see this remaining tumor. Next step, as I mentioned before, cutting the dura. At its lower aspect, this is the temporal dura. I will move forward. Okay. This is third division of the trigeminal nerve. Sometimes it's difficult to figure out the anatomy in this area. This is the moment of coagulating the superior petrosal sinus. And we also have to cut it. See the fifth nerve. This is the cisternal segment of the fifth nerve right before getting inside the Gesseran ganglion. And this is some crucial moment because see how the nerve is making this pronounced curve. And in this particular area, if you are not very familiar with this anatomy, you can cut the trigeminal nerve. I try in this case to push away the tumor, putting the bulging part of the intradural component of the tumor at the petrous apex, empty petrous apex area, just to ease the removal. As you can see here, we have displaced the tumor laterally, and with the ultrasonic aspirator, we remove this safe part of the tumor. And last part of the operation is just the dissection. This is the anterolateral portion of the pontine region, and the way we managed to very carefully dissect with the brainstem. The tumor was very adherent, very sticky, but we managed little by little, carefully, just to completely remove the lesion. See the pontine region, see the fifth nerve, and this is in essence the extended middle fossa approach. As I mentioned before, for number one indication, categories of lesion growing at the same time at the petrous apex and at the petroclival region intradurally. And this is the postoperative MRI with a pretty good result. In the second part of my presentation, how the evolving field of endoscopy also came to stay at the petrous apex area. In general, this is one of the pictures. This is a front view of the petrous apex taken from one classical publication of Dr. Amin Kassan. You can see ICA, petrous apex, Gesseran ganglion, third division of trigeminal nerve, GSPM after before and after getting converted into the median nerve. And first example, petrous apex lesion, petrous bone lesion. This is a cholesterol granuloma. We saw one of the examples before that by means of microsurgical by means of microsurgical approach. If you look at this CT scan, you can see how easily just going through the sphenoidal sinus, you can expose the lesion. This is carotid artery, and the lesion partially exists. In that case, you have to keep open this cavity, trying to avoid any refilling of the lesion over time. We have another typical example, another chondrosarcoma. This is a chondrosarcoma whose growing is restricted to the petrous bone. As you can see here, displacement of the internal carotid artery at the petrous segment, and this is the result. In that case, because of some very sticky and adherent plane to the carotid artery, we didn't intend to completely remove the lesion. There is some part of the lesion here, because assuming that is a chondrosarcoma, chondrosarcoma is a very highly radiosensitive lesion, and you have to take to keep in mind that before planning aggressive removal in cases of intraoperative difficulty. Second example, petrous bone lesion with posterior fossa extension. This lesion can be very similar to the one we saw at the extended middle fossa approach example. This is the lesion growing at the petrous apex, getting inside the petroclival region. This is the lesion at the petrous apex. Important to see by means of MRI and of course CT scan the extension of the lesion. We see the relationship with the internal carotid artery. We see how the lesion in that case is just going forward, going toward the jugular verb and foramen magnum and foramen and jugular foramen area. And this is important to keep in mind that because managing that part of the growing and extension of the lesion can be difficult by means of endoscopy. So endoscopic endonasal approach, middle and upper right turbinectomy, transclival, transpetrosal approach, inferolateral petroclival corridor, and after that for closure, nasoseptal and spinal drainage. Fortunately, the whole lesion was completely extradural and was a very easy, you can see the dura after decompression of the lesion. Unfortunately, this is immediate postoperative MRI with a very pretty good removal of the lesion. Third example, extracranial lesions. This is a 18 years old patient with this fast-growing lesion at the lateral aspect of cavernous sinus, trigeminal ganglion, and this infratemporal and pterygopalatine extension. Probably years ago, before the endoscopic era, we should have planned two different approaches, maybe one transcranial approach for that part and another approach with ENT for this second component, extracranial component of the lesion. You can see this huge component. So, but nowadays we can plan endoscopic approach that in that case provide a partial resection because the lesion unfortunately was a sarcomatous lesion, very infiltrating, and we just decided to carry out a partial resection as you can see here. This is another example. This is a trigeminal neuroma. One of the examples we have seen before, interdural lesion, extradural lesion, in that case with some component toward infratemporal fossa, as you can see here. And this is the way you can expose by means of endoscopic approach. This is the lesion exposed at the left side. This is the video removing the extracranial component of the tumor. This is after removal of the extracranial component and the way this extracranial component can lead you to inside the Meckel's cave. This is Meckel's cave. We are at the left side. This is temporal dura. This is the medial wall of Meckel's cave, that is lateral dura of cavernous sinus, and this is the last part of the operation, trying to remove the tumor at the porus trigeminalis. I think that the extension far beyond inside posterior fossa could be one of the limitations of the endoscopic approach. And this is our last example. This is a female, 73 years old, with recurrent chordoma after almost 15 years after the initial removal. This is the lesion at the petrous apex. You can see the lesion there. Removal. Unfortunately, we only have this postoperative CT scan with fat graft because at the immediate postoperative period, the patient have suffered MCA infarction. We tried with the help of the interventional radiologist thrombolysis, but unfortunately the postoperative course was very bad, and finally the patient died. This is showing that endoscopic approach, microsurgical approach, they both have some potential complication in this critical anatomical area. So this is my last slide regarding consideration about the choice of the surgical approach, microsurgery of endoscopy. I think that in every meeting we have some discussion about what could be the best approach. We have been working many years with microsurgical approaches, and I think we don't have to fight endoscopy and microsurgery. As you can see here, Charlie Chaplin, we don't have to that. What we have to do is try to have both approaches and make the choice according to your experience And for us, there are several issues. One important issue when making the decision is about whether the lesion is abutting sphenoidal sinus or not. If so, could be much easier through endoscopy. Is there intradural growing? Managing the intradural component of that tumor with endoscopy is not easy. Posteriorly placed, as we saw before, when the lesion is reaching the jugular foramen, you are about to deal with a long distance lesion with some risk of bleeding. Also, the vascular encasement, recurrent cases may be just make you tilt your decision toward a microsurgical approach, because vascular encasement may be more easily managed that way, and also the extension to the jugular foramen could be also a problem. This is more or less open for discussion. The key point when making the decision about microsurgery or endoscopy for Petroclival. I'd like to finish my presentation thanking again my good friend Ivan-Morcos for the kind invitation, all the University of Miami team, my very best regard to our very good friend, very much love in Spain, Professor Roberto Eros, and I hope that the operation Ivan-Morcos has to do today in emergency basis is going to be, as always, successful in his hand. Thank you very much. The brief summary. Anatomy, microsurgical and endoscopic approaches are useful, and those approaches are giving you access to the petrous apex, bone, petroclival region, pontine region, lateral wall of cavernous sinus, infratemporal and pterygopalatine fossa. Thank you very much.
Thank you, Dr. Arraez. That was fantastic. Wow, great cases. And we have some questions here from the audience. I'm going to go ahead and hold on to that until the end. And we get to some of the panelists and their cases. That way we can have a discussion, and then we'll wrap up with some questions. So Dr. Gentili, I think you are with us. Do you want to share your slides and show your case, please?
Okay, thank you. Can you hear me?
Yep.
All right, so I hope I can share my slides. Share my screen.
Yep.
Here. Can you see my screen?
Yes, that's perfect.
Okay, so first of all, I want to thank my very, very good friend Miguel for his excellent presentation, as well as Dr. Angeli. This is a very difficult area that we all know, and the importance of anatomy is so critical. That was very much emphasized by both presenters. So my presentation is a challenging case that we recently had, and I just want to get the analyst view and show you what I did, and we'll go on from there. So let's start with this. This is a 31-year-old female physician at 31. At the age of 24, that is 7 years ago, she presented basically with diplopia and dysarthria. She had negative past medical history, and on examination, she was entirely neurologically intact. So, of course, she was investigated, CT, MRI, and this is basically her CT scan. So what you can see here, the patient appears to have two lesions, one in the right sort of petrous area, and the other, both in the posterior fossa, as you can see here, and the other one in the left. They don't hedge very much, as you can see here. Looks like there's some erosion of the petrous roof here, and you can see some involvement of the mastoid cells that you can see here. This seems to be eroded. The CTA shows what looks like narrowing, definite narrowing of the sigmoid transverse sinus, but still, somewhat patent. The MRI scan is obviously much more, gives you a lot more information, and you can see now the two lesions. So she has a lesion on the left side, and this looks fairly uniform. Posterior petrous does not appear to involve the jugular transverse and sigmoid sinus. Very uniform. Looks like pretty much like a typical meningioma, doesn't it? However, the other side is a very much more complex lesion that we can see that was noted on a CT scan. This lesion looks like it involves the mastoid. There's been a sort of a filling of the mastoid. It looks like there's an intradural sort of, or at least extradural extension towards the posterior fossa with sort of a nodule in the lateral cerebellum. At the same time, it looks like it involves the superior temporal and petrous with, again, it looks like an extradural involvement. And you can see this here on the sagittal and shown here. So this patient, of course, had a full metastatic workup, which was entirely negative. So differential diagnosis. Well, you know, we talk to our radiologists. We have skull-based radiologists, etc., and we all put our heads together. And so, what is the differential diagnosis? Well, of course, multiple lesions. You always have to think of metastasis. That left-sided lesion looked like pretty much a meningioma, so maybe this was multiple meningiomas. Although the right-sided lesion was pretty atypical for, you would have to say, for meningioma. These other diagnoses came up, chloromas, sarcomas, atypical endolymphocytic sac tumor, which can occur in that area, as you know. Rosai-Dorfman disease came up, Wegener's granuloma, some atypical infection. There really was very, very difficult, and the radiologists were really not at all certain what was going on in the right side. They were concerned that, you know, to have two separate lesions, you know, so they somehow felt that these were related somehow. They were a little bit different, but related. So, management. What do we do? Like anything, right back to medical students, you can observe the patient, have surgery, radiation, and medical therapy. So what was done? Now this, I have to say, is before I met the patient. This was done, you know, was seen by another neurosurgeon, and basically he had surgery, but then he basically had a right mini craniotomy, sort of temporal craniotomy, and call it subdural resection, but to me it was really a general biopsy. I think that's what they did to try to sort out what the lesion was on the right side. So what did the pathology show? This patient had an extensive immunohistochemistry reviewed both in Canada. It was sent to the US to try to find out. The bottom line was this was a low-grade spindle cell neoplasm, not otherwise defined. There was no mitosis. There was some focal ossification, a low MIB, both S100s, estrogen and progesterone receptor, were all negative. Now, what about the differential diagnosis based on the pathology? Well, if you go, this is what it is. Fibrous meningioma, spindle cell sarcoma, solitary fibrous tumor, spindle cell carcinoma, synovial cell sarcoma, giant cell fibroma, fibrosarcoma, and myeloproliferative sarcoma. So pretty wide and, you know, and difficult to be sure. So what's the management now?
Why don't we stop and ask some of the group what they would do?
Yeah.
That's.
So Miguel, what would you do here?
Well, I think that, Fred, as always, you have difficult cases, my friend. Anyway, I think we had two lesions, one of them at the right side that is bigger, that is at the same time occupying some bony area, that is to say, if I may say, less risky than the other one. So I would just consider a transpetrous or trans-temporal approach, trying to remove all this bony component and also all the infiltration of the dura. Maybe the lesion at the transverse sinus, sigmoid sinus and junction can be removed because we have, sorry, we have good collateral venous circulation, and maybe the most taking into account all those possibilities and the possibilities of malignancy. I think that this aggressive approach to just going to remove the bigger lesion that at the same time, as I mentioned before, is mainly occupying the bony area. I think I would be in favor of that possibility. I don't know what Dr. Angeli thinks about.
Dr. Angeli?
I'm sorry, I was muted. Yeah, very interesting case. Thank you for sharing. I mean, I'm concerned about the large differential diagnosis here, including potential, malignant tumors in a young person. So I would recommend, to clarify the pathology, and if that biopsy was not complete, I mean, I agree with attempting a subtotal resection. I was wondering also, why does she has diplopia, but otherwise normal cranial nerves? Is that right?
That's correct.
Yeah, and what do we attribute the diplopia to? Does she have some degree of intracranial hypertension, perhaps, or I don't?
That was never really clear. So thank you for both of those, and so let's go back. So she then came to me. This is when I first met the patient, about a couple of months later after she had her biopsy, and interestingly enough, her symptoms had improved. I examined her and she was neurologically intact. She had a neurotology consultation. One of my colleagues, I don't know if you know him, Angeli, John Rutka, that we have here. She had a radiation because she was a doctor. Her father was a doctor. They really went everywhere, as usually they do. Medical oncology consultation. So when they came to me, I guess there were a couple of options that I saw in here. First of all, we had, unfortunately, a pathology that was not definitive, but it could be, a variety of things. But we have to say that these looked like a low-grade lesion, no mitoses, the others. So we could consider a aggressive transmastoid transpetrous right-sided resection of the lesion, as suggested by Dr. Arraez, or surgery for the left-sided lesion. Interesting. So what did I do? Well, interesting, I went for the left-sided lesion. Now you say, why would you do that? This lesion, is obviously asymptomatic, and it looks like, it's a pretty, what my thought here was, well, are these lesions the same lesions? We have to determine, are they the same? Or are we really talking about different lesions? And my thought was, this lesion is resectable. Everybody would agree that anybody see this lesion. So I could resect this lesion totally. At the same time, find out the pathology of this lesion and determine whether we're dealing with the same thing. Because if it looks like this lesion here may not be resectable and requires radiation, then if I've resected this lesion here, we may not need to radiate the other side of the brain. Now that was my thoughts. So I went ahead and did a left retrosigmoid craniotomy, got a total resection of that lesion. And what was it? Well, here it is. Looked like pretty much a meningioma to me. And in fact, we were able to get a nice total removal that you can see here. Nice resection. Pathology, benign WH grade 1 meningioma. Interesting. So totally two separate lesions. So then the issue comes up, okay, so now it's not the same lesion. So again, what do we do for the other lesion? Well, the family, as I said, they were really looked everywhere. They went to the States, they went everything. And ultimately, they basically elected on radiosurgery. The patient was totally symptomatic, neurologically. They were aware that an aggressive approach to that right-sided lesion would have risk, no question, to the cranial nerves, to facial nerve, and whatever, if you're going to do a very aggressive petrocectomy. So ultimately, they decided that they wanted radiosurgery, and they went to Boston, had 7 weeks a proton beam radiation, 70 gray, as you can see here. And in fact, after 6 months, it's her first post-rad MRI scan, and she had actually a bit of a response. You know, there was some reduction in the size of the lesion, shown very nicely here and down here. And this patient then basically was followed every 6 months, had an MRI scan. 6 years, as you can see here, the patient remained very stable clinically. She completed her residency and now was a consultant physician, and very stable. Everybody was happy, and we're all, very happy. 6.5 years. Just in May, this May, she had evidence, only 6 months from the previous MRI scan, evidence of recurrence. Where did it recur? It looked like basically recurred in the superior, petrous up into the temporal lobe. You can see some edema now on this temporal lobe, shown here. Again, interesting, the patient remained asymptomatic. So what now? Very quickly, Miguel.
You have to remove it.
Yeah, okay. Right. Well, remove what though? Remove the temporal lobe tumor or remove the entire petrous? So my feeling was that we had to find out what's going on here. Something has changed, as you agreed, from the previous thing. This is something now very concerning. So what I did basically was a right extended temporal craniectomy, basically. Remove this, and this was done only about two weeks ago, so that's why I don't have an MRI scan. But we see we've got a nice resection of the temporal tumor. We also tried to do a little bit of the superior petrous, so we basically took some more tumor from the superior petrous. But obviously, there was no attempt to get a radical temporal bone resection. Postoperatively, she did very well. She's neurologically intact. Pathology. The temporal lesion now was a very high-grade spindle cell neoplasm, very much increased mitosis, necrosis, completely undifferentiated. Interestingly, when I biopsied the lower part here, it remained a low-grade spindle cell sarcoma. The patient has had a very extensive panel of immunohistomolecular profiling, and again, it's interesting. They've sent it to Boston, everywhere, and again, not conclusive for lineage or definitive classification. So all they can say is basically a high grade undifferentiated spindle cells neoplasm, likely a sarcoma. And there was no diagnostic fusion gene, so this excludes synovial sarcoma or malignant solitary fibrous tumor, less likely than a myoepithelial tumor. So here we are now. She's 3 weeks out. She did very well. We have a very high-grade, undifferentiated spindle cell neoplasm. Now what, Miguel?
Well, I think that very bad case, but I think as a principle, maybe we have to see until which extent another aggressive operation could be taking into account the histology is not 100% clear, as sometimes happen in mesenchymal aggressive tumors. Maybe all we could do for this patient is trying to carry out a radical removal, transtemporal removal, trying to remove as much as possible. This is what we could do. Because and then maybe chemotherapy or radiotherapy. Maybe, why not, radiation therapy could have induced malignization of the tumor, I don't know. But maybe next step in a young patient with tumor still there, aggressive lesion, 70 degrees already, delivered to this area. Maybe all we could do is trying a radical removal transtemporal approach. I think it's feasible. I think that maybe more than 90-something% of the lesion can be removed.
Thank you, Miguel. Dr. Angeli.
I agree with what has been said. I just wonder why this lesion, became a high-grade undifferentiated spindle cell. Was this because of the radiation received? I mean, is that possible to determine that? Is it possible to determine that?
Yeah, that's a very good question. I asked our radiation oncologist, I said, this is a low-grade lesion, and she was stable suddenly now. I said, could the radiation, have, of course, the radiation, people always say, no, it's unlikely that these cells were there from the beginning and they suddenly sometimes can act up. But I'm a little suspicious that these could be, radiation induced, because you see the rest of the lesion seems stable. It's just this area that, superior that has flared up. So that, I'm suspicious about that, but the radiation oncologists feel that that's unlikely. In any case, Dr. Angeli, being an ENT surgeon now, would you do a radical temporal resection of this now very high-grade spindle cell sarcoma?
Yeah, I'm not sure that, if this is indeed a high-grade undifferentiated sarcoma, I think the surgery is probably not going to achieve an en bloc and total resection of the tumor. It would be very difficult.
Right.
I'm not sure. I mean, I think I would like to consult our hematology or neuro-oncologist and see if they have another option. I'm very, very concerned about the new pathology, and I think we have reached the limit of what surgery can offer as cure.
Yeah. Well, that's very, very, thank you for that. And really where we are now basically is, again, the family has sent around the world to try to get, an issue with regard to the molecular profiling, liquid biopsies, to in fact look at the aim of finding a targeted therapy for this lesion. Because I think everybody agrees. I mean, she's young, and I understand with Miguel saying, she's young, we have to do something. But I'm also of the opinion that I'm not sure surgery is the answer for this pathology. And so right now we're in the process of, let's say, of basically trying to get some targeted molecular profiling to see if we can get a targeted therapy for this young lady. She may very well end up, in the end, may have to do something surgically, but our current aim is to try to see if we can get some targeted therapy. So, thank you much for your attention and for your comments.
Thank you for that interesting case.
Yeah, that's a really tough case. Now, I'm imagining you've reviewed the proton radiation plan, and the entirety of the new tumor was included within that radiation field. Is that correct?
Yes, correct, Carolina. Yeah.
Yeah, it's a tough case in a young patient. Some of the limitations that way.
And she's still asymptomatic.
Right.
She's
Doctor, do you want to stop sharing your screen? Yeah. Do you want to stop sharing your screen for us?
Yeah,
and then,
okay. Yeah, where they stop sharing, yeah.
Perfect. And then Dr. Nanda, if you want to share your screen and present your case.
I'm going to unmute myself. Thank you. Is that projecting?
Yeah, if you could just go to presentation mode. Perfect.
Is that on? Okay, great. So this is, I was asked to pick up petroclival meningioma case. So it's great to be with good friends here and all these difficult cases. So I really enjoy it. And thank you for the University of Miami. And I hope Jacques' patient is doing great. So it's great to be among friends. So I'll quickly go to the case. I have 10 minutes. This is a 44-year-old female, had slurred speech, some difficulty talking. She had unsteady gait, right ear pain, lost the right side of peripheral vision with double vision. So we examined her. She had impaired tandem gait. I mean, she was using a walking stick. She had dysarthria, no facial weakness, and the other neurological exam was fairly normal. This is her MRI. So, there's a little bit of hydrocephalus there. This is the sagittal MR. And this is the coronal films. So while we're presenting this, any people are, what approach and what would you like to do? Obviously, this is too large for radiosurgery. And so this was the preoperative imaging that I just shared with you. So I think the question is, what approach would you use? I think almost everybody would agree in a symptomatic young patient. And what is the aim of the surgery? So we can open that up to the panel, and then I can tell you what I did. Caroline, if you want to ask any questions. Yeah.
So we could just, Dr. Arraez, what would you think about this? How do you think about a lesion of this size? How does that change your thoughts about the approach?
Who did you ask, Carolina?
Dr. Arraez.
Yeah, Arraez. Miguel.
Oh, sorry. Well, I think we are just in front of a young patient, as Dr. Nanda said, big lesion, symptomatic lesion, brainstem distortion. First of all, I think there is clear indication for surgery. Second, the lesion could be a meningioma, not only a meningioma. I see some atypical features, but in any way, is a lesion that is, coming from the dura at the PETROCLIVAL and tentorial area. And talking about the surgical approach, to my mind, I think the simplest, probably most effective and faster approach is a classical retrosigmoid approach. I don't see lesion just going around the tentorial incisura to think about more complex approaches like petrosal approaches or things like that. I think I would approach by means of retrosigmoid approach.
Any of the other panelists do something different?
I was just curious about the patient's hearing, both ipsilaterally and contralaterally, and whether there's any
No hearing loss.
yeah, and no hearing loss, so normal hearing in both ears.
Normal,
And
yeah.
the vestibular function, I guess, is wasn't measured, wasn't provided. But I don't want to get into the. I don't want to guess what Dr. Morcos would do or ask me to do, but I think this lesion is anterior to the internal auditory canal. So some type of temporal craniotomy is probably going to, I think is probably going to recommend to reach the anterior most portion of the tumor without so much retraction. And it may be also an option for some of the pre-sigmoid combined with temporal craniotomy approaches.
So in the interest of time, I can tell you what we did. We rendered the retromastoid approach, and I think I can show you the video here. Seventh and eighth cranial nerve were in front of the tumor. It wasn't, you get very disappointed when you have a soft tissue. You get mad with God, like, why did you do this to me? So it was not a soft tumor. So we worked between the cranial nerves, and I went to the petrous apex, and you can see here we're dissecting that. We separated from the cerebellum. Quite firm. I don't know what we do without the CUSA, so that kind of helped us get more. Then we did internal decompression. And here, fairly adherent. Wasn't one of those soft things that comes right out. We had the superior pole right there, taking more tumor off. And there's the fifth cranial nerve. And we're getting it off the brainstem at this stage. You see the other cranial nerves, you'll see them in a minute. Very fibrous. And yeah, I knew I wasn't going to get the whole thing. I felt that if I left 1 or 2 centimeters, anteriorly, we weren't going to get there and get most of it off. She was very symptomatic. She was really disabled, couldn't walk. So I was really concerned. I felt if we decompressed her well, it's quite vascular, some big vessels in there, but we were able to get a lot of it out. So this is the upper part near the tentorium. And I knew I'd left a little bit of tumor up there superiorly. And here you can see the brain looked very relaxed. This is the post-op MRI. And this is just to show you the post-operative imaging here. And you can see we did leave some tumor behind. You compare the pre-op and post-op here. Fairly clean. You see this medial aspect right there. That's what we left behind. I didn't think that, we published on this. I prefer to just do radiosurgery up front. So I did her about 4 months ago. She post-operatively, she had like a grade 4 facial, which I was surprised because intraoperative monitoring was very good. We did gamma knife radiosurgery on her 6 months later. Her facial nerve actually has completely come back. It's just maybe a grade, very mild paresis. Here you can see her face 6 months post-op. And this is our series that we published on petroclival meningiomas. I wish I could tell you they all do great. I think this is a difficult case, and I think the classics always tell us what to do. In the Iliad, Achilles you choose between Kleos or Nostos, glory or a safe return home. And I think we always struggle with getting a beautiful looking post-op MRI and quality of life. So this is our series, and our total resection rate, petroclival meningiomas, we had very good outcomes. It was only 28%. So I stayed in my 10 minutes. I want to thank you guys. I want to invite all of you for our global neurosurgery meeting over 3 days. So we have a good lineup on that, and we're going to have the Sir Michael Marmot on healthcare inequities after COVID. I think healthcare changes are important, and everybody's sensitive to that. And at the height of the COVID epidemic, we had this beautiful rainbow over New York City. So that was a sign that all will be well. So I want to thank everybody. I stayed within my 10 minutes. So I'm open. I'm going to switch sharing my screen.
Thank you, Dr. Nanda. Question, was the pathology, was it grade 2 or grade 1?
Grade 1. And one of my concerns with meningiomas is when they got to liberalize the grading. We are seeing now 30% of meningiomas are coming grade 2. And the radiation therapists have a really itchy trigger to radiate these tumors. And when they're large, they're like zap the whole field. And when we published our cavernous sinus series, we found the control rates are much better with upfront radiosurgery. The Karolinska group echoed the same sentiments. So I'm a believer in earlier radiosurgery. I might be over-radiating. I can tell you, like a tumor like this, our radiation therapists, they were like, no, you should radiate the whole thing. If it was grade 2, they would zap one oculi to and I think Fred, your case was beautiful. There's dangers to proton therapy. I don't think there's doubt in anyone's mind that this is a malignant transformation, secondary radiation. The one person who was doing cartwheels with that case was Osama Al-Mefdi, because he's always speaking against radiosurgery or surgery. So I was like, oh my God, I could hear him.
Now, did you wait, because you had a facial nerve palsy post-op, did you wait the 6 months to do the radiation?
Yes, I just did her, but her facial nerve is fine. It's actually moving down to Florida, so it's going to Palm Beach. I'll make sure she follows up with you guys.
Sounds good. Actually, there's a question. I'm going to stop for 1 second to ask a question from the audience that pertains to this case. This is from Dr. Onia, and they're saying, for those of us practicing in developing countries, sometimes intraoperative monitoring during retrostig surgeries, especially for facial nerves, not available. Apart from clear understanding of the anatomy in each patient, are there any helpful suggestions or techniques to minimize facial nerve or vestibular or eighth nerve injuries that you could advise?
I just think you have to be very meticulous, and I'll tell you, I was a resident in Pittsburgh, a fellow at Pittsburgh, and Majid Sami, who do an acoustic. It was one of the high points of my career. I assisted him with the, you know, it was like watching Michelangelo paint, and I'm watching him do an acoustic, and the guy needed no monitoring. He needed nothing. He was ready to lumbata and the posterior fossa before you know it. Oh, this is. So I think for people, if you know, I mean, he didn't need monitoring, and I think if you just learn the anatomy and respect it, you'll be fine without monitoring. So I don't think it's a necessity. I mean, I still use it because I like to morally tell myself, okay, the nerve, you know, tested well at the end, and I'm going to be fine. And in this case, it tested beautifully, and she had like a facial palsy. So I was like, oops, I'm not that good. You know what I mean? And fortunately, she got it back. So
Great, thank you. All right, you want to share your screen?
Yeah.
I feel good about sharing my screen with a fellow New Jersey person.
It's good to see everybody, and thank you, Dr. Morcos, Carolina, for having me. Great talks today by Dr. Angeli and Dr. Arraez, and very lucky to have Dr. Angeli and Dr. Morcos as great mentors here at Miami. So today I just want to present one of these interesting cases. It's a complex lesion. This is a patient, a 51-year-old, who initially presented in 2014 with episodes of facial weakness for 2 years prior to that. And then during that 2014 ER visit, she had kind of a 2 or 3 day gradual onset to eventually a House-Brackman 3, normal hearing, and she presented in the ED with both CTs at the same time. So she had a CT here in 2012, which is normal. And then in 14, having this small erosion, basically just at the petrous apex, kind of where the geniculate ganglion would be, just in this one area. Unfortunately, at the time, it was missed, and it was read as normal. And so she was then diagnosed with the Bell's palsy, and then treated with medications. This obviously didn't improve, and that's just the first part of the story. But interesting, I mean, this ended up being a facial nerve schwannoma, and just at this stage, if it was diagnosed at that time, I guess my first question to the panelists would be, you know, a small facial nerve schwannoma at the geniculate ganglion, House-Brackman 3 with the hearing intact. You know, what would your approach be to this? Resection, decompression of the nerve, only radiation or observation?
Dr. Angeli, do you want to comment?
Thank you, Michael. This is one of the cases I like. When I was a fellow over 25 years ago working with Dr. Brackman in Los Angeles, he asked me to write the experience with observation of facial nerve neuromas and observation and decompression. And I wrote a paper, a series of few patients, and immediately I became an expert on decompression facial nerve neuromas, and I still get calls from lawyers to deal with these cases. So at least in our specialty, we feel that we should observe or even, you know, attempt to decompress when possible these tumors that they very slow growing and can go, you know, can be very indolent for many years. Obviously, you don't want it to get beyond, you know, just to recap, facial nerve function of 3/6 in the House-Brackman scale. The patient still able to close the eye with some effort, but able to close the eye. So there's some asymmetry at rest, but it's a tenable situation. Probably not better than what you're gonna get by resecting the nerve and patching up together the nerve. I think the jury is still out about radiation therapy of these tumors, and I've had patients. I have sent patients for radiation of facial neuromas, and I've had mixed results. Those who immediately develop a worsening facial nerve function and don't do well, and others that, you know, have some response to radiation, and the nerve never improves, but it stays stable for a long time. So until we can determine whether radiation is a good approach, I'd probably recommend my patients to wait as long as they have a 3/6, and unless there is any imminent erosion of the labyrinth. And you know, as you can show in this CT scan, the expansion of the genicular area is very close to the superior semicircular canal. But if you see any evidence of imminent erosion into the cochlea, I would probably feel more comfortable doing something, because the patient may lose the hearing from just a growing facial neuroma, even when the facial function stays the same. So for tumors like this, we would recommend if there's a ongoing dysfunction or complaints or concerns about erosion of the labyrinth by the growing tumor, I would probably recommend a decompression first, especially if the patient is relatively young and doesn't have any major comorbidities. I would, we'll probably do a transtemporal craniotomy, decompress the labyrinthine segment of the facial nerve, the geniculate ganglion, and you can go from the middle fossa into the middle ear and decompress further beyond that area if you need to, or do it through the mastoid if you need to. But decompression can afford even some tumor growth without functioning, without decline function. So that's probably what I usually recommend.
Great. No, thanks. And I think we've done that with some of the other tumors. Obviously, this is an unusual case, otherwise I wouldn't be presenting it. So the patient was lost to follow-up, presented 4 years later with complete facial paralysis. Actually, I already had a gold weight placed at that period of time. Complete hearing loss, headaches, gait instability, dizziness, memory loss, nausea. And this was the CT at that time. This basically shows complete erosion of the entire left temporal bone. And you can kind of start seeing where we're going here with this case, that it's just massive expansion of this tumor in 4 years' time when she was complete loss to follow-up there. Extending all the way from the temporal lobe down to the jugular foramen on the left side. Her MRV shows that the jugular foramen is open, sigmoid sinus, transverse sinus is open on that side. And so then, so these are kind of some of the pictures. Obviously, a large tumor, obviously, surgery is indicated. I think at the time, at this point, the question is, why did this grow so fast? Is there a chance that this is a malignant nerve sheath tumor? Does that change your approach to this resection? Would you do a biopsy to prove that? Would you do an angiogram considering the involvement, as you can see down here in the carotid? And would you consider facial nerve reanimation at the time of surgery? So I'll just maybe open it back up to Dr. Arraez and Dr. Angeli on those thoughts.
Thank you. Well, I think that I would carry out aggressive removal, and just if you follow the tumor in some sort of, let's say, transpetrous resection, you can reach the posterior fossa component of the lesion, trying to carry out let's say a radical, or in as much as possible radical removal of the tumor. This is the way I would plan this case. I think facial nerve repair could be done in a second stage, of course, but the main goal would be the removal of the lesion that is going a big mass effect on the temporal lobe and posterior fossa structures.
Okay. Any other comments?
How long have they been House Brackman 6?
It was like over a year.
Direct reanimation, I think, is probably not going to work here.
Yeah, exactly.
What would you have done with that first scan, though, Jamie?
Yeah, I mean, that's a great question, as pointed out, but that, the labyrinthine segment was dilated, as Dr. Angeli pointed out. I think a decompression makes a lot of sense. We don't operate and reanimate until they're 4 or worse. We may, if with evidence of growth, because the CT from before to the second shows growth, we probably would have gamma knifed at that point in time. But then you guys would all say that this is radiation induced.
Exactly. So just in the lieu of time, because we're running short, we did do an angio. There was no collaterals. And then we decided to do, obviously, an aggressive combined approach, no animation due to the timing. So we did a left combined middle fossa translab transcochlear because her hearing was out. And then you could see here with a neck dissection, because it did go down to the jugular bulb. Large fat graft was placed. It was a good resection. And then the path was actually interesting. It came back as a cellular schwannoma, which are a little bit different than your typical facial schwannomas. So much more common to have this extensive bone erosion, faster growth, and occasional necrosis. And they often are confused for malignant nerve sheath tumors. And here's just a paper that shows that differential, kind of the differences between them, and also the progression-free survival and the overall survival is vastly different, as you would expect for both kinds of schwannomas. But in our case, there's a low Ki67, 1%, and the only thing that was a little bit strange was that it had extensive necrosis. So I just saw her back last week. She's a 2-year follow-up MRI here. Shows, it looks good, no recurrence. Her facial nerve is still out, obviously. She's elected not to go any kind of reanimation at this time, but otherwise she's doing well and back to work.
Great resection there, Mike. Great case. All right, one more. All right, Jamie, you want to share your screen?
Yeah, thank you. Let me just get this up. Can you see this?
Yeah, if you could just go to presentation mode.
If it lets me. Ironically, I thought we were going to spend a lot more time talking about meningiomas with this talk. And I wish I would have put what Mike and I call skull-based GBM is one of these very challenging petroclival meningiomas. And I guess before I go into this case, because this is a humbling case that I think people that are going to hang on to are going to learn something from. But when you guys have large meningiomas, I guess, and you're thinking about working around the temporal hiatus, I want to know what people's thoughts are about sacrificing the fourth nerve. I know we're surgeons that try to save function at all costs, but when you have large tumors, I'm interested in what the panelists think about just intentional sacrifice of the fourth nerve for more resection.
Dr. Gentili, what are your thoughts?
I think I don't intentionally sacrifice it. I often it will go, despite my best efforts. So in the end, obviously, if you can get a total removal, then I think a fourth nerve palsy is something that they have to accept. What can I say in terms of strabismus surgery and so forth? It can be dealt with. So that to me is not a major postoperative morbidity.
Anybody else thoughts? Because I used to agonize over this a lot, but for an increased resection, I don't know if people know this or not, but 10% of people have a fourth nerve palsy congenitally. And I was taught that by a ophthalmologic surgeon I do transorbital surgery recently with. So I just wanted to say that that's something we shouldn't agonize over as much. Anyway, I have a case that I think people will learn from. So this is a 51-year-old with intermittent diplopia, horizontal in nature, worse when looking to the right. She had birth-related trauma and cerebral palsy, which was evident MRI with prior encephalomalacia, with a prior right MCA region stroke. She has a history of seizures, which have been controlled since '84 on phenobarbital. And about 3 years ago, 3 years before her presentation to us, she had an abrupt onset of facial nerve palsy, diagnosis of Bell's palsy without further imaging. It was House Brackman 6. So on exam, she's House Brackman 6 on the right. Unbeknownst to her, she has no hearing on the right side, which she doesn't know when that dropped out. Her tongue is midline. No evidence of trigeminal neuropathy. She does have some diplopia on extreme right gaze, but yeah, nothing visible on external on exam, and she has her spastic right arm from her CP. And she has this lesion in her right petrous apex. It's diffusion restricted. It goes down into the clivus below the jugular foramen. Does not contrast enhance. And it's quite a sizable multi-compartmental lesion. Here's a CTA demonstrating its expansion into the clivus medially. And on the right, in the interest of time, I'll just fire through these. General benign remodeling of the petrous apex and occupied of this lesion that we can all argue, is it a cholesteatoma or a petrous apex epidermoid, but one of the two things. And I'll say, so one thing that kind of, well, I'm just interested in in what the panelists would do with this particular case. Dr. Angeli?
Yeah, that's a great case. I would go for if I had to bet, I would bet for this being an epidermoid tumor, given that doesn't restrict. And I would probably recommend a transcochlear approach, given this patient is deaf in that side, provided that she has good hearing on the opposite side and good vestibular function. I think it would be a quite direct shot to the tumor, to the core of the tumor. I don't, it's very hard to be radical and be convinced that you have removed the entire tumor, but I think that's a good shot, through a transcochlear approach to get to the center, the bulk, and then work around the perimatrix to get as much as you can of that epidermoid. And I always counsel patients that these tumors tend to, it's possible that we leave residual tumor that we may have to go back again. And if we had to go back again, we already have that path created for us through the petrous bone to get to the residual tumor in a few years down the road.
There is.
Dr. Arraez?
I would use a retrosigmoid, and very similar. However, they should not be radical. It's impossible. I did my fellowship with the Aspergill, and spend 10 hours trying to get the capsule of these epidermoids, whatever, and it's disaster. Cranial nerves and so forth. Do not attempt a radical removal. Get all the contents out. And my average, after now 30 years, has been a decade that I've had these have recurred, and after a decade, I've had to go back. They're benign tumors. The last thing you want to do is cause morbidity in the patient. You can do a beautiful decompression, remove it all. I love these cases because they're avascular, and so don't be radical. You can get a very nice removal, and the approaches. I think either it's just what you're comfortable with. I do these retrosigmoid.
Fred, if it's completely extradural, which this one is, I'm assuming that you wouldn't do it retrosig, correct?
I'm sorry, say that again?
It's a completely extradural lesion. I'm assuming you wouldn't do it a retrosigmoid, right?
No, if it was a totally extradural, but if it's an epidermoid, and I'm not sure if Dr. Angeli said he felt this was a cholesterol granuloma. Based on the thing, I think this is most like an epidermoid. And those are not extradural; they're interdural tumor lesions.
No,
So
I said epidermoid. I think I said.
Yeah. So the epidermoids, I say, are not extradural lesions.
Well, yeah. So this one is a completely extradural epidermoid. But Dr. Arraez, what would you do?
Well, I think this is one of the cases of epidermoid at the petrous apex, probably, and I think this is a very good example of three possible approaches. One of them, as Dr. Agnelli mentioned, a transotic approach. Another one, the possibility of anterior petrosal approach to the petrous apex. That is an approach, as I try to show in my presentation, that may avoid any damage to the hearing. And there is a third possibility that is an endoscopic approach through I have seen the lesion in some way abutting the sphenoidal sinus, and I think this is also a very good example and very good indication for endoscopic approach. I think these three possibilities are good, and nowadays I've done many cases. I've done some epidermoid of the petrous apex that is different for the intradural classical epidermoid in neurosurgery. But although I have done in many cases the transpetrous approach, I think in that case I would try an endoscopic removal of the lesion. And of course, this is chimeric to think that you can completely remove the tumor and the capsule, maybe too aggressive and too risky. And I think that removing all the soft content of the lesion and capsule in as much as possible, but for sure you won't be able to remove completely this capsule. I think that this approach of trying to remove in as much as possible could be good enough. We have to take into account that the rate of growing for epidermoid cyst is the age of the patient at the time of diagnosis plus eight months. So as Dr. Gentili mentioned, I think that removal in as much as possible, not necessarily 100% aggressive, could be enough for that case.
Thank you. Dr. Benjamin or Dr. Ivan, any different thoughts?
You know, I think the endoscopic approach is interesting here. And the other question was, what's the patient's, you said that they had cerebral palsy, sort of what's their, you know, functional status? You know, you want to consider that in terms of how aggressive you're going to go with this.
She's very functional, self-cares and independent with a job.
Okay.
She just has a lazy arm.
Yeah, so I think the transmaxillary endoscopic approach might get you a lot here, especially if, you know, if it turns out being an epidermoid, which we're sort of thinking along those routes, it might just sort of be a nice suckable way to remove this. What did you end up doing?
So I'll not put the video in, but prior to this is I had a patient come in 6 months prior to this that auto-decompressed the petrous epidermoid that we were watching to the nose. It had an event. So we thought it would be a smart idea to go through the nose. So we went ahead and we you know, did our resection through the nose. The IAC's over here, jugular foramen's down here. Got a very nice resection and had dura. So this is all dura. And thought that we would lay a nasal septal flap against the dura and treat this like a cholesterol apex granuloma, in which we would just drain it through the nose. And that's kind of the crux, is I think that this is where the learning point comes in on this case. So we had a nice resection. Patient did very well, and did well for 28 months. And then at 28 months, the patient came in with nausea, fever, stiff neck, and we did a lumbar puncture and the patient developed meningitis. So now the patient now has a petrous apex that probably isn't recurrent tumor. It's probably in that cavity. And I guess the lesson that I've learned here is that nothing's a better medium for infection than skin tissue. That's what's left over, obviously, these things. And that opening must have closed off over time. And now, since talking to other people about this case, I've heard of about 4 or 5 of other cases like this out there. So this isn't something that I think that probably was a good idea. We did an endonasal opening of that and debrided it. Patient developed a CSF leak. Obviously, there was erosion of the dura from the infection. And then went back and repaired that CSF leak. So now 3 years later, after the meningitis, this thing refilled up, no new symptoms. So we did a transcochlear as a next step. And I guess the lesson I learned from this case is it was very inviting to do this through the nose, but I think this is a very sterile lesion that I can't completely remove. And if these tumors present themselves to the dura, I think I'm gonna do what you suggested, Dr. Benjamin, probably a transmastoid endoscopic procedure, a transcochlear endoscopic procedure. Any other comments from our panelists?
No, it's interesting. You know, I do a lot of endoscopy, and I think, you know, the issue is that, just as you said here, this to me is yeah, there's a high risk here in terms of the potential for infection. So I would not have done it.
Yeah, I just want to say that, you know, one of the problems with the transcochlear approach is the posterior mobilization of the facial nerve, but this patient already has a facial nerve paralysis and is deaf. So I think it's kind of a direct shot to the lesion. And I have cases not as big as this one where we have left the just the same concept that we do for large cholesteatomas of the temporal bone, where we do a radical operation and create a cavity that we can debride periodically in the office to avoid, growth of the tumor or contamination of the tumor. So that's another thought. So that's probably, I feel more comfortable talking as a neurotologist with the transcochlear approach for something like this rather than going through the nose. But I see that some of the smaller lesions may be amenable to a nasal endoscopy approach.
Tough case too.
Okay.
Well, okay, thank you very much. You can stop sharing your screen. We've answered a few of the audience's questions along the way, but we just have finish up with a few questions here. All right. One of the questions was to Dr. Arraez, that one of the one of the audience members asked in terms of when to use the lumbar drainage. For when you're doing your cases, do you use it every time? Do you use it for intradural, extradural? When do you choose, and how do you go about that decision making?
Thank you. Well, I think that if you are going to do any approach to extradural lesion, I mean transcranially, to the petrous apex, you have to reflect temporal lobe, and so you have to use lumbar drainage. If you are going to do some sort of approach with some part intradural, you can take advantage of that to release CSF, and you don't need the lumbar drainage. This is our policy.
All right. One question was to all the panelists just regarding the use of in which cases do you use angiogram when you're seeing displacement of the carotid artery? Do you ever do a BTO, or is that something that you don't really come across as needing? Dr. Nanda, what are your thoughts on that?
Unmute myself. My age, the lag time increases. Do you want to repeat that question again?
I'm just saying, in terms of the use of angiogram and the need for a BTO in any of these cases where there is vascular encasement or displacement of the carotid.
The older you get, the KISS principle applies. Keep it simple. I don't necessarily test. I don't embolize meningiomas, maybe EVMs and stuff. I'm just very, very. I keep it less. I belong to the minimalist school, so that's my thought on that.
Great, thank you, Dr. Angeli. Somebody is asking, how do you assess and treat tinnitus in the case of a vestibular schwannoma? Kind of a large question there.
Yes, it's a large question. Thank you for the question. As you know, tinnitus may be one of the presenting symptoms of acoustic neuroma, especially if it's unilateral. And the way we do it is we do a hearing test. We assess the hearing level. We can do some tests to try to, the first question we ask the patient is the tinnitus bothersome or not bothersome? And, a lot of patients have tinnitus, but once you reassure them where the origin of the tinnitus is, then they usually understand and feel less anxious about it. Most of the patients with tinnitus, with acoustic neuromas that present with tinnitus, will have it for the rest of their lives, regardless whether you treat the tumor or not treat the tumor, or even treating the tumor is not going to take away the tinnitus. It may make it worse short term if you attempt to remove the tumor or radiate the tumor and have and then unluckily you get a sudden hearing, sudden change in hearing. But tinnitus is a tough symptom, and I don't think I can go on for hours on how we assess it. We assess it with objective ways and self-reported ways, and we kind of measure. Those measures help us know how the patient is doing. And there are a number of strategies to cope with tinnitus, essentially not to cure it, but to decrease the awareness or help the patient decrease his or her awareness of the tinnitus.
Great. And then another question for you, Dr. Angeli. Somebody's just asking, what do you think is the most valuable work that you can get with a retro lab or a trans lab that you can't do with a retrosigmoid?
Well, that's a great question in this you know, for most neuro-otologists like myself, we feel very comfortable working presigmoid. Whereas I have learned today, I mean, over the years as well, that neurosurgeons can do anything they want retrosigmoid as well. So I think it comes down to one, anatomy, and two, your comfort level with the approach. But pretty much you can, you know, if you're comfortable, you can reach many corners. And if you have the favorable anatomy, you can reach many corners with both approaches.
Good.
All right, that was it in terms of the audience's questions. Thank you very much, everybody. Dr. Angeli, Dr. Arraez, great talks. Dr. Arraez, I know it's probably 1 in the morning there, so thanks again for sticking with us. And to all the panelists and everybody who joined, thank you very much. Hope to see you guys next week.